So, Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the Saudi Society of Pediatric Dentistry webinar. This is Linda Mirza. I'm a pediatric dentistry consultant at King Abdullah Medical Complex in Jeddah, and I am a board member of the society. First of all, Mr. Bilal. First of all, on the behalf of the Saudi Society of Pediatric Dentistry, I would like to say to the audience, كل عام وانتم بخير. رمضان مبارك. أسأل الله سبحانه وتعالى أن يتقبل منا الصيام والقيام وصالح الأعمال وأن يزيل هذا البلاء ويرفع الغمة عن بلدنا وعن سائر بلاد المسلمين. So welcome again to our webinar. This webinar is organized by the SSPD, collaboration with Kunuz Ritaj Company. This activity is accredited by 2 hours accreditation from the Saudi Commission of Health Specialties. It's my pleasure to moderate this session tonight with Dr. Basil AlKhadra. Dr. AlKhadra is a pediatric dentistry consultant. He graduated from King Saud University and he got a dental master degree from University of Minnesota. Good evening, Dr. Basil, كل عام وانتم بخير, and welcome to our webinar. Dr. Basil? Dr. Basil? Okay. I think Dr. Basil cannot hear me.
Okay. Inshallah, it's an honor to be with you.
Welcome to our webinar, Dr. Basil.
I can hear you. Can you hear me?
Yes, please. I just would like to welcome you to our webinar and كل عام وانتم بخير.
وانت بخير والجميع بخير. Thank you. It's a pleasure to be with you tonight. And it's a long-awaited moment to see such functions serving the dental population of Saudi Arabia and the region.
Yeah. Thank you so much. It's an honor to have you tonight. Me and Dr. Basil are hosting 2 distinguishable speakers. Let me introduce the first speaker tonight, Dr. Bashaer Abdulhadi. Dr. Bashaer is a senior registrar in pediatric dentistry at King Fahad Armed Force Hospital in Jeddah. She had her master and PhD certificate from King Abdulaziz University. She is a member in Prince Mohammed bin Salman Autistic Center, and she is the Deputy of Dental Assistant Program. Dr. Bashaer will talk today about a very important topic, which is communication in dental setting. Dr. Bashaer will discuss for us today different communication pathway. She will state for us how can we communicate with our colleagues effectively and how can also communicate with the patients, including identifying and meeting patients' needs. So before I give the mic to Dr. Bashaer, I would like to assess your knowledge about Dr. Bashaer's topic. So I will post in the screen 2 poll questions, and I would like to ask from all of you to select the best answer for each question from your previous knowledge. Mr. Bilal, can you please post the questions in the screen, please? So, perfect. Now you can please select one best answer for each question. The first question, what methods reduce stress in dental workplace? You have 4 options: minimize staff, good communication, voice problems, and list possible solution, multitasking, overbooking appointments. So this is the first question. The second question, what is a characteristic of good listening skills? It is one of the easiest skills to master, should not be influenced by a person's appearance, and it does not require you to look at the speaker. And the last option, letting your mind wander when talking to the patient. Your time starts now. You have 10 seconds to select the best answer for each question. Okay. Time's up. Mr. Bilal, can you please stop hosting? Thank you so much. So I will thank you so much for answering. We will know the correct answer at the end of Dr. Bashaer's presentation. Before I give the mic to Dr. Bashaer, I would like to highlight that if you have any question that is related to Dr. Bashaer, just please write your question in the QA box in the bottom of your screen. We will try to answer most of the question at the end of the presentation. I really wish that you will have a great time. Dr. Bashaer, the mic is yours. I wish you all the best.
Assalamu alaikum wa rahmatullah. Ramadan Kareem alaykum kullakum, inshallah. First of all, I would thank you, Dr. Linda, for the kind introduction. And also, I would thank the organizers for having me today. It's my absolute pleasure to be part of this wonderfully arranged webinar. So let me share the screen with you. Okay, today I will talk about the communication in the dental office, and I would like to spend a few moments with you to walk you through a topic not merely related to my area of expertise as a pediatric dentist per se, but it is widely relevant and important to the entire team as a whole. Let me begin with you asking these two questions. First question, when was the last time that you have difficult communication with an angry or upset patient or patient's parent that you feel yourself incapable or did not know how to deal with him or her? The second question, how many of you have faced a patient or patient's parent who do not value or understand the recommended treatment by you as a dentist? So I hope by the end of this lecture, you will be able to highlight few keys of communication skills that is critical for the entire dental team. And it's not just the dentist or dental assistant, dental hygienist, but also for everyone to be able to help motivate and achieve optimal oral health. So let's start first with the objectives for today. We will explain why it is important to understand human behavior and describe cultural diversity, discuss communication pathways, and identify the differences between verbal and non-verbal communication, describe the importance of communicating effectively with colleagues, and discuss communicating with patients, including identifying and meeting patients' needs. First, we should know that a good communication in all forms is the backbone of a well-run organization. Learning about interpersonal communication allows you to communicate what you mean and to interpret what others say and do correctly. Understanding the human behavior is very important, and it is the collection of actions performed by human beings who have been influenced by a person's culture, attitudes, emotions, values, ethics, and authority. The behavior of people can be viewed as normal, common, acceptable, or even unusual or unacceptable. We all, as a pediatric dentist, heard about significant people in psychology, especially in the section of behavior management. And today we will take a quick look on some of these significant people. There have been several psychologists, just a second, yes. There have been several psychologists who have been instrumental in researching the way we understand how individuals behave in their personal and professional life. First, we will talk about Sigmund Freud, and he considered to be the father of the psychoanalytic psychology. He stated that people have conscious and unconscious thoughts, and our purpose in life is to control our instincts and the power of these thoughts. Also, we have Erik Erikson. His theory was that the person's identity is individual and it comes from the past and from one's heritage. Also, I think all of you heard about Carl Roger. He stated that human beings are intrinsically good and friendly. They are born with these qualities. It is society and their surroundings that diminish these qualities. And we are, as Muslims, we know that say from Prophet Muhammad sallallahu alaihi wasallam, قال رسول الله صلى الله عليه وسلم عليه ما من مولود إلا يولد على الفطرة فأبواه يهودانه وينصرانه ويمجسانه إلى آخر الحديث. Then also we have Jean Piaget. Piaget developed the first theory of child cognitive development. Before his work, children were believed to share cognitive processes of adults. He believed cognitive development was an active process, not something that children passively acquired. Skinner, B.F. Skinner, he assumed that behavior is learned. Any behavior that is a threat can be changed by learning to solve problems. Positive behavior is acknowledged and encouraged by positive reinforcement. Again, now we are as a pediatric dentist, we use this positive reinforcement all the time with our pediatric patients and kids in the clinic. Finally, we will talk about Abraham Maslow. He believed that humans cannot live without needs, and he categorized the needs in groups with different rankings. Abraham Maslow created Maslow's hierarchy of needs. And this is the Maslow's hierarchy of needs. As we see, most fundamental needs at the bottom, and the need for self, it will be the psychological need, and for the self-actualization at the top. In other words, the theory is that individuals' most basic needs must be met before they become motivated to achieve or pursue higher level of needs. Social attitudes. As a person grows and develops in life, social attitude begin to influence behavior and cultural way of thinking. We tend to internalize the attitudes of others around us, making their attitudes our own. Peer pressure. We often have the tendency to adapt our behavior so as to fit in with a particular group. Peer pressure is seen when a person conforms to the general behavior of a group of peers in an attempt to feel more acceptable within that group. And the peer pressure could have a negative or positive effect. Cultural diversity. Differences that must be appreciated and understood includes the gender, race, cultural heritage, age, physical abilities, and spiritual beliefs. Verbal and non-verbal language varies among cultures. So we need to encourage all members of our team to learn various cultural traditions and always show respect for these traditions when providing patients care. For example, in this diversity, we can say that this diversity can be found even in most of undisputed cultures and habits. For example, it is well known that the patients and people in general appreciate the handshaking, of course, before the corona time. Especially in the first meeting, and this show respect. But in some cultures and some societies, handshaking or shaking someone's hand gives a bad first impression. So that's why we need to be aware about the culture, the culture and the culture that we are dealing with. Effective communication is one of the most important aspects of dentist's job. We spend most of our day communicating with others. We communicate with words, facial expressions, appearance, gesture, mannerism, listening, voice inflection, attitudes, and actions. The two parts of the message identified above are grouped into the two general categories of verbal and non-verbal communication. Regarding verbal communication, it is made up of words that we use. Words are very important. Always select words that will not frighten, intimidate, or upset a patient, especially like us in the pediatric dentistry, we are dealing with kids. So we need to make sure that these words will not intimidate them or frighten them. For example, instead of saying pain, we can say discomfort. Instead of saying shot, we can say anesthetic. Or for the little kids, usually we refer to sleeping juice. Instead of pull a tooth, we can say remove, or say ممكن بعض الأحيان نقول لهم حنقول مع السلامة للسنة. We need to understand the level of understanding of our children and deal with them according to that. Also in verbal communication, we need to be aware of the voice quality. We need to monitor our tone. Also in regard of asking questions, we need to know what question to be asked. We have the closed-ended question, and we can answer the answer of these questions with yes or no, or the open-ended questions are those that require more than a yes or no for an answer. So in the event of, for example, in the event of a true emergency in the dental office, it is particularly important that you be extremely careful to keep your voice calm, because it is not what is said, but how it is said. That may alarm the patient or the persons accompanying the patient. We should take care what to say and how we can say it. The body language in the non-verbal communication, it's the message we send, the way we carry ourselves and move about. Posture, movement, attitudes transmit major messages. Facial expression as well indicate a wide range of emotional states. We can see in this figure many examples. I will use this one. We can see, like in the first picture to the left, we can see two examples. How we can understand the feelings of the person from their gesture, from their hands, the legs, how they cross their hands and legs. So we can understand the openness here versus defensiveness, evaluation in the second picture versus suspicious, readiness versus boredom. And you can practice, if you want to practice how to understand people from their body language, you will find a lot of exercises and pictures. You can go through it and do many exercises. Listening skills are a very important skill. To be a good listener, do not let your mind wander. Put aside all personal concerns while the patient is talking. Do not concentrate on formulating a reply. Concentrate on what the patient is actually saying. Look as well as listen. Pick up both verbal and non-verbal information the patient is transmitting. We need to know that failure of communication is the major reason patients leave the practice. Major reason that make the patients leave the practice, and also lead to patient dissatisfaction, and sometimes it reaches a lawsuit. So listening requires a great deal of self-control and concentration. Here are some more ways to be a good listener. Do not stereotype a person's appearance, cultural background, race, or religion should not influence your response. Be careful of selective hearing. Sometimes we hear only parts of what someone is saying. Do not get impatient, especially if the patient is a child or an older adult. I think all of you face these kinds of patients when the patient is uncooperative, screaming, kicking, and already you are losing your patience and you are wondering when this visit is it will be finished and the patient will be dismissed. So sometimes, unfortunately, we ignore some of the parents' questions or comments. Communicating with colleagues, working in a positive, challenging, and stress-free environment is what everyone wants from their place of employment. A patient can tell right away what level of harmony exists in a particular dental setting. The one key to a successful work environment is teamwork. So how you can be in a teamwork? You should be flexible and receptive to altering the way responsibilities are performed. Be self-confident and use self-initiative when it is time to get things done. Show appreciation to co-workers. Think before speaking. Do not let your emotions get overly involved. Remember that the first impression is not always the right one. Share the ups and downs of the day, and your way may not always be the right way. Let's talk about the stress in the dental office. An important aspect of good communication is how you handle stress in your personal life and at work. The dental atmosphere can be a very stressful environment, and this can affect the way you deal with your patient and co-workers. The causes of stress in the dental office could include lack of sufficient staff, appointment overbooking, multiple tasks required simultaneously, lack of good communication, perceived lack of job advancement. Okay, how can we deal with these stress, and how these are some of the methods of stress reduction? You can reduce the stress by maintaining a lifestyle that includes regular exercise, taking time for yourself, leaving the office behind at the end of the day, eating properly, setting realistic expectation. And we need to learn to control stress, because this will enable us to make intelligent decisions regarding patient management, patient care, and patient relationships. Also, sometimes we face a conflict between the co-workers. If differences or conflict among colleagues are creating stress, learn how to work through those differences by engaging in team-building dialogue. Conflict is necessary as well for effective problem solving and for effective interpersonal relationships. Unfortunately, if we ignore these problems, it will escalate. Now we will talk about communicating with our patients. Effective communication is important in achieving patient satisfaction. Patients who have good relationships with their dentist and the dental staff are likely to stay with the practice, accept the treatment presented to them, pay for their treatment on time, and refer other patients to the practice. Okay, what are the patient needs? Patients build their relationship with their dentist and dentist staff through confidence and trust. Patients base their perception about a practice on the following factors: how they are treated on the phone, how they are greeted when they come to the office, how they are made to feel in the office, and how efficiently the staff manages business aspects such as billing and insurance. The psychological needs of the patient, more obvious when a patient appears tense, suspicious, apprehensive, and resistant to suggested treatment, one major factor is the patient's current life situation. And we need to know that establishing a positive professional-patient relationship is part of understanding the needs of the patient. As a dental professional, you must recognize that patients are different and have different needs. Other important factors are previous dental experience, attitudes, and beliefs about the importance of his or her teeth. Anxiety and fear of pain. Again, I think all of us as a pediatric dentist, we face a lot of patients coming with anxiety and fear. For many patients, it is the expectation of pain, not actual pain, that causes the greatest distress. Subjective fears, also known as acquired fears, are based on feelings, attitudes, and concerns that have developed at the suggestion of peers, siblings, parents, or other individuals. While the objective fears, also known as the learned fears, are those related to patients' experiences and his or her own memories of those experiences. Dental phobic patients. For some patients, the more suggestion of a routine dental visit can bring an overwhelming sensation of panic and terror. Patients with most severe cases of dental phobia avoid routine treatment completely. They will seek urgent or emergency treatment with the most aggravated of dental symptoms. Patients' responses are influenced by the patient's total personality and by background experiences. A patient's response to the situation results primarily from causes that are not part of the present situation. Causes are probably not understood by patients and will most likely remain unknown to us and as a dental team. The patient's anxieties concerning treatment may result in hostile, irrational, and inappropriate behavior. Hostility is an expression of a patient's anxiety and is not caused by or directed at the dental personnel. As well, we shouldn't take it personal when we face patients dealing with these behaviors. Physical and mental needs. Maintenance of high standards require sensitivity to the patient's physical and mental needs. The patient registration form and the medical dental history form should include questions about the patient's dental and medical health. Patients with physical or mental impairment have complicated and special needs that must be considered before and during provision of dental treatment. The financial needs. Often a major obstacle to patient acceptance is the cost of the treatment, especially with the kids and with the pediatric patients when the parents think that these are only primary teeth and it will fall down and no need for us to treat it. So patient may believe that the fees are too high, they are unable to afford the treatment, that they do not need the treatment. Many people do not equate dental care with basic human needs, such as shelter and food. Getting people to understand the benefits and the advantages of appropriate treatment requires good communication skills. Meeting the patient's need. We need to make sure that the atmosphere is positive. We treat the patients with sincerity, showing respect, respecting the patient's time, resolving complaints and misunderstanding, remaining approachable, and respecting patient confidentiality. To ensure that the patient feel welcome, create an environment and a decor that reflect a warm hospital and atmosphere. Patients are especially sensitive to the tone of the voice, as we mentioned before in the verbal communication. and remarks remarks that could be misinterpreted. Scheduling appointment and staying on time are two essential components of helping patients feeling welcome. Here are some of my lecture references. Thank you very much for listening, and I appreciate your time.
Thank you so much, Dr. Bashaer, for this informative lecture. I really enjoyed it and enjoyed all the information that you discussed today. So can you please show us the reference again? So if anybody is interested in further reading, he can capture the screen now. Thank you so much. And if anybody has any points, need more clarification or any comments, he can contact, or he or she can contact Dr. Bashaer at her email. Dr. Bashaer, oh, thank you so much. This is the email of Dr. Bashaer. Now, Dr. Bashaer, can you just please give us the correct answers for the questions that we posed in the beginning of the lecture?
Yes, of course.
The first, yes, please.
Here, the first question was, which methods reduce stress in the dental workplace? The correct answer is B, good communication, voice problems, and less possible solutions. The second question was, what is a characteristic of good listening skills? And again, it's B, should not be influenced by a person's appearance.
Thank you so much. Mr. Bilal, can you please show us the percentage of the answers that the audience did in the beginning? Oh, perfect. So the first question, we got 82% of the audience. They correct the answers. They answered the question correctly. And for the second question, we got 49% of them answered correctly. This is a very promising information. So now let's go to the discussion. Dr. Bashaer, I have one question. I think body language plays an important role in communication. Can you please give us examples or brief advices? How can we improve our body language?
Thank you, Dr. Linda, for this question. It's really important, and maybe because of the limited time, I didn't emphasize more on that topic. But we need to know that many of our mannerisms are subconscious, and we also read other people's mannerism subconsciously. But body language, especially our control over it, can also be quite conscious. So by identifying the habits you have that do not serve you well and adopting new habits that increase the engagement factor with other people, you can consciously improve your body language and hence your communication skills. And all of these skills can come with more practice and reading on that topic. So like for example, some of them, not all, we can be aware of how we cross our legs, our hands. We need to make eye contact, relax our shoulders while we're talking, face your conversation partner, know where your hands are. Sometimes we are playing with the pens or we're playing with whatever around us. And we need to be relaxed.
Okay, sure. Okay, I have one question. You know, the current situation due to coronavirus, it's a stressful situation. And as a health worker, we have more stress. So can you give us any advices? How can we reduce all the stress that we are facing as a health workers and in the same time in this global crisis?
Yes, of course, it's a bit difficult time for all of us, especially for us when we are facing these infections every day. Then we come back to our homes,
Yes.
for our kids and families. So we need to concentrate on a more healthy lifestyle. Maybe if we do a schedule for us every day, like exercises, reading, spending quality time with our kids and our families. It's really help يعني especially يعني I'm talking about my personal experience. It's really help us.
يعطيك العافية. أنا عندي سؤال معلش هقوله بالعربي جانا في الأسئلة. صراحة سؤال جدا رائع. هقرأ لك هو: مرحبا دكتورة، كل عام وأنت بخير، شكرا على المحاضرة الرائعة. عندي استفسار: لماذا عند إدخال الأطفال غرفة العمليات يفصل تماما عن والديه ويبدأ بالصراخ والخوف حتى يتم تخديره؟ لماذا لا تبقى معه الأم أو الأب ويحمله بلبس جاون، يعني يخلي الأب أو الأم يلبسوا جاون يكون مع الطفل ويكون معه حتى ينام؟ أتمنى أخذ استفساري بعين الاعتبار وطلب تطبيقه كباقي أغلب المستشفيات حول العالم لما أراه بالنسبة للمعاناة للأطفال في عمليات طب أسنان الأطفال. تفضل دكتور. على الجي اي بيكونوا كونشيس، فإنه المستشفيات ما راح نقول الكل بما بيعملوا oral sedation أو يعني بيفصلوا بيعملوا separation while the child is conscious، فبيكون بتأثر نفسيته جدا. طبعا بعض المستشفيات
هو هذا اللي كنت حابة إنه أوضحه، إنه يعني يمكن تجربتها كانت يعني في واحدة من المستشفيات بهذه الطريقة، ولكن في العموم يعني أغلب المستشفيات يعني الطريقة المتبعة إنه إحنا بنخلي الأهل يدخلوا. إحنا عندنا يعني مكانين من يوم ما نبدأ نحضر العمليات. في عندنا مكان اسمه holding area، وبعد كده في غرفة العمليات. الهولدنج اريا هذه بنسمح للأب أو الأم، واحد يعني من البيرنتس، إنهم يكونوا مع الطفل. طبعا يغيروا له ملابسه، يلبس لبس الخاص بالعمليات، وفي هذا المكان بنلبس الأم أو الأب بنلبسهم الجاون وبنلبسهم اللي هي الأشياء اللي هي متبعة للحماية وتقليل الانفكشن، لتقليل العدوى، بحيث انهم يقدروا يجلسوا مع ابنهم او مع ابنتهم الى ما يجي وقت العمليه. وكمان بعد كده كمان دكتور التخدير عاده في الاطفال بالذات الاطفال الغير متعاونين بيعطيهم زي شراب يشربوه كانه عصير، هذا نسميه يعني سيديشن قبل العمليه، نعطيهم هو بحيث انهم يهدأوا ويكونوا ريلاكس. لما يجي وقت ما ندخلهم على غرفة العمليات ما نواجه صعوبة حتى بالنسبة للأطفال ولا بالنسبة للأهل، يعني يكون الطفل خلاص تقريبا يعني ما هو نايم بس شبه نايم ويدخل بهدوء. فأنا ما أعرف إيش التجربة اللي واجهتها، ولكن صحيح فعلا في بعض الأماكن أو بعض المراكز يمكن ما هو متوفر عندهم هذا الدواء أو ما هو متوفر عندهم يعني كل الفاسيلتيز هذه.
يعطيك العافية. طيب بالنسبة للجود listening skills، في بعض الحضور سألوا التبس اللي ممكن يبدأوها علشان to improve good listening skills. What do you advise just to start as an initial step to improve my listening skills?
We can practice. Of course, all of us يعني بنواجه هذه المشكلة إنه especially we are facing many patients a day. Sometimes in some centers we are seeing until 10 or 11 patients a day. And for us, the questions seems to be repeated and it's the same and already we know the answers. So we need to practice. Everything can come with practice. So we can practice to be aware of the parents' words and be aware of their questions. Of course, because of course not all the questions need the same answer. It's not easy, but it's not impossible. We need to practice, and they will find a lot of tips and videos that can help them practicing listening.
Thank you so much. Thank you so much, Dr. Bashaer, for your informative and interesting lecture. Now we will go to our second presentation. Dr. Basil.
أيوة معكم.
So you can.
And thank you so much. So I'm asking Dr. Abdulfatah to start sharing his presentation, please. Dr. Basil, the mic is yours.
Thank you. Our second topic today will address a global issue. The World Health Organization statistics shows about 5 billion people worldwide are affected by tooth decay. Out of these, about 60 to 90% of the school children are affected by tooth decay. And about 5 to 10% of budget spent on the treatment healthcare is dedicated for dental care. To address these issues and in a smart way, we have tonight Dr. Abdulfatah AlAzmah. Dr. Abdulfatah obtained his bachelor degree from King Saud University and his doctorate in dental science from Eastman Dental Institute in United Kingdom. Dr. Abdulfatah is currently the Vice Dean of Clinical Affairs at the Dental College of Prince Sattam University in Al-Kharj. Dr. Abdulfatah, we're pleased to have you tonight with us to discuss the smart treatment options for children. The mic is yours.
السلام عليكم مساكم الله بالخير الله يعطيكم العافية جميعا. Good evening everyone. It's an honor to be with you today and many thanks for the organizers and the Saudi Society of Pediatric Dentistry for the invitations and organizing these seminars during the last 4 weeks. Today, inshallah, we are going to discuss the smart treatments option for children. And why do I call it smart? It's because when you are providing a healthcare service for children, it's always challenging. So you have to be smart and wise and use your time efficiently and select your treatment to be the most beneficial for the child. So the problem that we encounter as a dentist worldwide is dental caries. Nowadays, dental caries is the most common childhood disease, affecting more than 6 million children worldwide, according to the WHO. If we want to talk specifically about Kingdom of Saudi Arabia, we will find it among the highest countries affected by dental caries, unfortunately. Going directly to the Ministry of Health website, we will find some facts on oral and dental diseases. And here we can highlight that the percentage of children aging 6 to 12 suffering from tooth decay is 96 and 93. Another study by Dr. Al-Ansari is giving us the same number regarding children and adults these times. And I think the high number will make us to think about why do we have these high numbers in the country? Is it because that we focus more on managing caries, or we have lack in the education to the children and parents in order of giving the prevention that we need to give? Because if we compare ourselves to other countries, they still have a high percentage of dental caries. However, they are improving yearly or like in time, not like us, who've been in the same high percentage for a very, very long time. Another question is, if we have high percentage of children affected by dental caries, are all the children are receiving the proper dental care that they should be received? I don't think so. So some of the children will be left with untreated dental caries, and then they will face the consequences of having untreated dental caries in their mouth. And these consequences are going to affect their daily life directly, like their eating, drinking, sleeping. They will be more in need of medication sometimes, like analgesics, antibiotic, and in the worst case scenario, they will be admitted to the hospital as a consequence of dental caries. We can see here a figure from the United States of America in 2011 to 2014, stating that 25% of children did not receive treatment for dental caries. So if we are going to discuss any smart treatment option, I think we should mention first the prevention. الوقاية دائما خير من العلاج. So the prevention is the #1 smart treatment option. And we always go and find some very good references in the AAPT guidelines. regarding the caries risk assessment and prevention protocol that we should give to our patients. And here I mentioned another source of information, which is the Department of Health Toolkit. The Department of Health Toolkit here is giving us a very nice prevention advices. If you open the Department of Health Toolkit, you will find these summarized schedules, and it is age specific, as you can see here, and divided between the advice to be given to the patient and the professional intervention that you have to do. And different in color here. Here is the normal patients, and here is the high risk patient. So it's good source and recommended. One more point I would like to stress on the prevention is the early intervention. The first dental visit should be 12 months or earlier, so we can educate the parents how to take care of the oral hygiene of the child, plaque control, diet advice, educate them about teething, about early childhood caries. I want to mention one example from United States in 2003, where they found that the number of caries in permanent teeth is decreasing. At that time, the number of early childhood caries cases was going up. One of the reasons why, at that time, the recommended age of the first dental visit was 3 years of age. And at that age, the child will come, and some of them will have early childhood caries, and it is too late. So it is good to mention always the first dental visit to be at 12 months. As professionals, for prevention, we can always apply fluoride topically in the teeth. So this is the only thing that I am going to mention about prevention, which is the fluoride varnish. The fluoride varnish is a preventive, effective, and strong type of fluoride, and which should be recommended by the evidence base. So if we are going to do fluoride topically for our patients, please let us use the best one, and which is nowadays is the 5% sodium fluoride varnish. It's been proven to be very effective for prevention of caries and for high-risk patients by reduce the caries in the primary dentition by 37% and in the permanent dentition by 43%. It's easy to use, contains xylitol, flavor, so some children will like it, sits upon contact with oral fluids, so there is no need to ask the child to keep his mouth open. The American Academy of Pediatrics recommended the application of 2 times at least, and sometimes 3 times per year for high-risk patients for maximum benefit. As I said, it's easy. The way of application is just isolate the teeth, dry, and apply on all surfaces for 30 minutes and leave it for 30 minutes. So if we apply all the prevention advices and intervention that we can do, and we have failed, and the child is now having dental caries, we have to formulate a plan for this child for managing dental caries. And in order to do so, we have to consider any barrier that can be a problem when we deliver our treatment. So the most common barriers, or some of the barriers we have here in pediatric dentistry, is the age of the child, pre-cooperative children less than 4 years, uncooperative children, children who does not accept local anesthesia or refuse hand pieces, or the difficult itself is difficult for the child, or number of treatment needed is high. And we don't have to forget the medical history, which is essential, and patient with special health care needs. Usually, when we have any of the categories I have mentioned, the most common treatment that we propose to our patient is general anesthesia. However, if we going to refer our patient to general anesthesia, we will face long waiting list in the governmental sectors and high cost in the private sector. So it's not a direct forward option to solve dental caries, and sometimes the parents would refuse the GA because of its risks. So we will leave the child with pain during eating and sleeping, days missed at school, so his education will be affected, behavioral problems, weight loss, so his growth will be affected as well. Sometimes affected self-esteem, confidence, and ability to smile. This example here is from United Kingdom between 2015 and 2016, while the dental rehabilitation for children to treat caries is the first cause of admitting children to hospital, counting for more than 43,000 general anesthesia for children in 1 year. So do we have to refer all the children or all the uncooperative or children with limited cooperation to general anesthesia? No, we don't. Do we have other options that we can consider? Yes, we do have other options. Are these options the ones that we have to consider is evidence-based? Yes, it is evidence-based. In order to do so, we have to divide our patients to two groups. The first one is the cooperative child, the one that we see here. If you have a cooperative child, inshallah, we'll all have a cooperative child always, which I don't think so. You can choose the treatment that you prefer if it is evidence-based and the treatment will...
دكتور عبد الفتاح.
نعم.
معلش اعتذر منك على المقاطعة، بس في بعض الناس بيشتكوا من الصوت إنه هو شوية واطي، فإذا ممكن بس تعلي صوت حضرتك شوية. والشيء الثاني الحركة الكثير I think في الميكروفون بتقطع شوية أو المشكلة في الإنترنت، فبس حبيت أوصل لك الملاحظات اللي جاتنا، وأنا آسفة على المداخلة مرة ثانية.
الآن أفضل؟
أيوة، هي يمكن الحركة تعرف مع الميكروفون بتسوي زي تشويش، وكمان طالبين الصوت حضرتك يعلى شوي. يعطيك العافية وآسفة على المداخلة. تفضل.
Okay, شكرا دكتورة. So the first group here is we have the cooperative child. The cooperative child, you can choose the treatment that it suits you, and if it's evidence-based and the treatment will meet the child needs and will leave him with a good oral health and will relieve his signs and symptoms. The other group is the uncooperative child with dental caries, and again, we are going to divide this group to two subgroups. The first one, the child in your clinic, and this child is reporting signs or symptoms of infections, or the caries is already proximal or into the pulp. For this group, since they are uncooperative and they do have signs and symptoms, we have to use the pharmacological behavior management approach like GA, the one that I have mentioned before. So the focus of our lecture today is going to be for this group. When you have a child in your clinic and this child is not complaining from any signs or symptoms, there is no infection clinically and radiographically, and the caries is not yet into the pulp. For this group, we can consider what we call the biological approach of managing dental caries. Of course, we can consider the biological approach for all the patients, either cooperative or with limited cooperation, but we consider it more especially when we have this subgroups that we can see here, the preschool child, children with early childhood caries. When the cost is a consideration for the family, we know that caries is unfair disease and caries affects poor children more than others. So sometimes when you propose a treatment with a lower cost and it's evidence-based, the family would appreciate that. If you want to avoid GA for medical reason or because of the parent's refusal, if you want to buy some time, especially if you want more teeth to erupt in the case of the second primary molar, and when you have patients with special care needs, or to avoid results. If the child does not want the handpiece or cannot accept the handpiece, or in our time, the time of the coronavirus, when we have the dentist at the highest risk of having the infection, and we cannot deliver the treatment unless it's emergency, and the recommendations nowadays by the EDA that the patient should be examined for the coronavirus and he should be negative, and then you can provide a treatment. So avoiding aerosols fits under biological approach. So the biological approach is when you treat the process of the caries and you make the caries lesion arrested, mostly when you do local anesthesia or remove the caries. So how can we apply the biological approach for our child patient? In order to apply the biological approach, we have first to have a careful history medically and dentally. So we have to make sure that our patient is medically fit, and then to make sure that he is not reporting any signs or symptoms of pain or other signs or symptoms. Following that, we have to diagnose caries clinically and radiographically. For the clinical examination, we are going to use the International Caries Detection and Assessment System, the ICDAS. It's the system with a primary code from 0 to 7, when 0 is no caries, sound tooth, and 7 is extensive caries. We use it in the biological approach because the clinical appearance correlates with the histological status. So when we link these two together, the score will guide us either to use prevention or restorative management. We can see here the ICDAS. Here we have the code 0, which is the sound tooth, and we have 4 codes in the blue area here. And this is the area when we can arrest the caries and use our biological approach. I have to admit that sometimes it's difficult to assess number 4 score, and you have to do more careful examination. But you can consider doing biological approach for these scores. So what is biological approach? It's when our understanding of caries advanced greatly over recent years, and it's now understood that caries is a dynamic process with the phases of demineralization and remineralization. Depending on the balance between these two stages, the caries will go further or the region will stay the same. So is it evidence-based? Yes, you will find a lot of literature supporting the biological approach since 10 years till today. And like this study here, when they confirm that both the conventional and biological treatment approaches have similar final outcome and were equally successful for management of caries lesion in the primary dentition. So what options do we have under the biological approach that we can use? The first one is pit and fissure sealants. We've been using nowadays pit and fissure sealants for more than 50 years, and we know all of us that pit and fissure sealants is used primarily for prevention. We want to prevent dental caries, especially when we talk about the permanent molars, and it's proved that it's reducing the dental caries to 50%. But the new thing that we should consider after we understand more the caries process is we can use fissure sealant as a secondary prevention when we have occlusal caries, uncavitated, limited, and concise to the enamel. We can refer to this evidence-based clinical guidelines by the ADA if we want to use fissure sealants for prevention in 2016. And here we can use pit and fissure sealants. Many types is available, and the literature did not give us a clue which type is better than the other. However, we use the resin-based sealant mostly, and we consider glass ionomer sealant when we have limited cooperation or moisture control is compromised, or we have partially erupted tooth. Here we can see the steps of doing pit and fissure sealants. I am sure that we are all familiar with these steps. The most important one is isolation. If you can isolate properly, you will have a good fissure sealant. Here we can see the evidence. If we have an initial caries and cavitated lesion in the enamel, we can use pit and fissure sealant to stop this lesion. Sealants for prevention and arresting pit and fissure occlusal caries in primary and permanent molar. They concluded available evidence suggested that sealants are effective and safe to prevent or arrest the progression of non-cavitated caries lesion compared with a control without sealant or fluoride varnish. And further research is required to recommend which sealant material is better. So the evidence suggests that perhaps in 1 in 10 lesion, the progress will be arrested, the progress will go. So we have about 90% of success. All sealants or any biological approach that you have to consider should be maintained and followed up regularly. Final evidence about the pit and fissure sealants from the Cochrane, and we know that we always have the best evidence from the Cochrane when we have here about 8,000 children. Data from 7 of this study was pulled together and showed that 40% of back teeth developed decay over 2 years. Using a resin-based sealant reduced this to 6%. So we will have, because of having sealant, we will have this 40% become to 6% in children aged 5 to 10.
Dr. Abdulfatah, I have to interrupt you again, sorry, but the voice, again, we're having problem with your voice. Would you please make sure the mic is close to your mouth and not to have any interruption? Thank you.
Okay, 1 second. I will just pause for a second. So I hope that this is better.
It sounds better, thank you.
Okay, so these are some cases that when we see caries in the enamel, we don't need to remove the caries if you have a limited cooperation from the child, or if you want to consider this as the first treatment option you have. So you can go over and seal the fissures, and then the caries will be arrested and you will not have progression in the lesion. So what if we have the cavitated lesion? What if the caries went further and now the region is cavitated? We have another smart option under the biological approach, which is the hole technique. So we've been using the stainless steel crowns, or we call them sometimes preformed metal crowns, since 1950s. The hole technique is defined as a method of managing caries' primary molar teeth by cementing preformed metal crowns over them with no local anesthesia, tooth preparation, or caries tissue removal. So this technique is named after Dr. Norma Hall in Scotland, when she used this technique for over than 15 years and she retired. And until today, we have a lot of great evidence going on regarding this technique. So basically, if you have a cavitated lesion like this one, you can, under certain criteria, select the proper crown size and fit it directly on the tooth without local anesthesia, without preparation, without caries removal. Now, they prefer this technique in the UK. It's the preferred technique by the pediatric dentist specialists in the UK. So, as we said, for any biological approach, the caries that we see, it's the reflex of what's going on in the plaque biofilm process. And if you seal, you will have arrested caries after a while. Effective sealing from the oral environment can cause the necessary environment to change, resulting in plaque losing its cariogenic potential for as long as the seal is maintained. So the whole technique is one method that we can achieve the seal that we need. So this study is one of the first studies regarding the evidence of the whole techniques, and it is by Innes in 2011, when we can see that 17 different dentists work in this study, and the success rate is high and good. So when we can consider doing the whole technique is when we have cavitated lesion, as we said, class 1, or cavitated or uncavitated. More important here is to take a preoperative peri-apical radiograph to make sure that there is no infection and the caries is still at the first layer of the gene, you can go ahead and perform your hole on the tooth. On the other hand, when the tooth is non-restorable or the caries is deep and proximal to the pulp, you can see here as in this tooth or deep like this one, or we notice any signs of infection, we cannot consider using the biological techniques and the whole crown. So what are the disadvantages? Of course, the aesthetic, because it's due to a silver color, and temporary bite opening because we don't perform any preparation to do the whole crown. So if you decide to do a whole crown for your patient, the case selection is the most important step. And like this one here, you have to select the case and check the contact if you have a contact to fit the crown, and then you can go to protect the airway, select the crown size and do not push it fully because it will stuck in, then load it with the cement and do your initial cementation, ask the child to bite, and finally clear all the cements. So if you don't find a space mesially or distally, you can create some space by placing separator for several days and seeing your patients again, or modify the crown that you have. Here is one study from Germany. They suggest they did two types of crown, which is underhole. So the design, patient records of children receiving whole technique with or without proximal slicing. So the patient that they have interproximal space, so they went without proximal slicing, which is the typical whole technique we know. Patients that they don't have spaces between their teeth, they did what they called modified whole technique, and they did some slicing between the teeth in order to whole technique to be fitted. The success rate of the whole technique in this study was 92%, and in the conclusion, they found no significant difference between the whole technique and modified whole technique when you do the interproximal slices. So this study is a recent one, which is the day before yesterday. It was published online comparing the whole technique to the conventional stainless steel crown after you do the preparation. And here I am not pointing to that whole technique is better than the conventional technique that we do usually for the stainless steel crown. I am pointing that we have to consider both techniques because they are both successful. However, this study found that the whole technique is a bit higher in success rate. And of course, you will find another study that is telling the opposite. So both techniques are good, both techniques are highly considerable, and the success rate is more than 90%. The big question about the whole technique is the occlusion. So it's a common sense. You did not do any occlusal reduction, and then you fitted a crown on the tooth. Of course, you will have a high occlusion point. So if this occlusion point is correctable, the occlusion is going to be the same like before. Yes, it will. But how long it will take? So we will find some studies saying it will take 1 day, some others 2 days, some others 1 week. So I found this interesting study, which is very recent as well. If you can see here, it's published 5th of April, 3 weeks ago. Digital occlusal analysis of vertical dimension interclassical position after replacing of stainless steel crown using whole technique in children. In this study, they used 3D scanning technology to measure the occlusion before and after the whole crown, and they said that it takes maximum 1 month for the occlusion to be completely normal as before. So there was an occlusion equilibrium after 1 month. Here is the case from the same study I mentioned for the digital scanning. This is the way, and this is the occlusion before and after. So I like to use or consider whole techniques in cases with the enamel defect in the primary second molars. And this is one of my patients who come to the clinics complaining of discoloration of the ears, and they advised him to go for GA while he is not having any clinical or radiographical signs or symptoms. So I proposed whole technique in order to protect these teeth from breakdown or caries, and the parents agreed. And we have here this photo after 1 month from the visit for lower ears. Same case, different patients with an X-ray taken. So we've discussed two smart treatment options. The first one is where we have uncavitated lesion and you can fissure seal it and you will stop the caries from the progression. The second one, when you have cavitated lesion enamel and dentine, and you can consider doing your whole crown for the patient without giving local anesthesia or caries removal. The last smart option that I am going to discuss is the silver diamine fluoride, which I consider a new trend because we've been using it now for like 3 to 4 years. It is a type of the fluoride which contains 38% SDF, as they said. It is a technique that is going accepted worldwide because it's easy and affordable, and the action is arresting the progression of the caries lesion. What I more like about it is that we can use it for cases of early childhood caries. The previous option that we discussed is fissure sealants and the whole crowns. We cannot use them for anterior teeth. However, this one, silver diamine fluoride, we can use it for both anterior and posterior. So as I said, it's 38%. The main component is silver particles, accounting for 25% as antimicrobials. We have ammonia 8% for solving, and 5% of fluoride for remineralization. So the silver ions act for breaking the cell walls, and then it disrupts the microbes, and then it attaches to the DNA to stop and arrest the caries lesion. So a lot of literature is going on regarding SDF and proving the efficiency of the technique. But the recommended one is the one published by the American Academy of Pediatric Dentistry in 2017, use of silver diamine fluoride for dental caries management in children and adolescents, including those with special health care needs. So nowadays, it's mostly used for primary teeth, especially early childhood caries, and for old patients, and to treat root caries in the adult patients. The advantage is it's affordable technique, inexpensive, easy to use, non-invasive, require minimal training, bactericidal effect, arrest the caries, and it increases the access to care. However, despite the great effect of the silver particles in the SDF, the same silver particle result in staining of the caries leading to turn black like this one, from this normal caries color to black stain that we can see here, which is good and not good. Good because we know it is working, and not good because the patients and the parents would not like it sometimes, especially if we are talking about the primary anterior teeth. Here we have some cases while we use SDF, and here the black discoloration is significant. We can see here 2 years follow-up of primary proximal caries, and we can see here that the teeth are about to exfoliate normally. So it's contraindicated and not recommended with patients with silver allergy, and the contraindication of any biological approach when we have deep lesion or any signs of pulpitis or other infection. In order to do and apply SDF for your patient, you have to have informed consent, like for any other procedures, and you have to use only plastic dip and dishes because it's very strong agent and it will ruin anything else that you will use if it is not a plastic. The way of application is easy. Isolate the extraoral tissue, remove and clean food from the lesion and make it ready. Dry, then apply the SDF for 30 to 60 seconds in order to arrest the lesion. Remove excess SDF, reapply every 6 to 12 months. So one bottle usually costs $170, and it is enough for 30. Inshallah, DF is going to be available in our site from June. We're about 1 month from now. I contacted the company that is going to be responsible to distribute SDF, and they will have it inshallah in the market in June. So it's good to consider it as an option. So what is our concern regarding the SDF is the aesthetic because of the black stain, and it's always been a big question about the SDF. I found a review, which is a recent one as well, very beneficial because it is measuring the perceptions and
I really apologize. I think Dr. Abdulfatah has a connection problem. Dr. Basil?
I lost him as well.
Yes.
So
So until Dr. Abdulfatah rejoin us again, I have some questions from the audience, Dr. Bashaer. Dr. Bashaer? Dr. Bashaer, can you hear me? Dr. Bashaer?
Dr. Linda,
Yes.
اسمعيني.
Yes, please. Until Dr. Abdulfatah rejoin us, I have some questions from the audience, so we can, if you don't mind, can I ask you please some of the questions that we received?
Yes, of course.
Okay. How can we deal with dental office conflicts?
Okay. This question is really important because, like, I don't think that anybody who's practicing dentistry or any other work, he didn't face these type of problems. Every day we're facing conflicts in the office and even in our homes with our kids, with our brothers and sisters, and we have to deal with all of these conflicts. In my opinion, we take it to the conversation level. We need to make a dialogue. I need to raise the issues that I'm upset with it, and we let a healthy conversation to be there, so we can reach, inshallah, to a good solution. The most important that we are not taking the things personally, because once we're taking it personally, it will be so difficult to resolve it. Especially at work, we need to be a professional as much as possible, and we're not taking any of these conflicts as a personal issue.
I have another question, please. It's regarding parent separation. I will just read this question for you. From here. Okay, I have another question. I lost that question, I'm sorry. So what do you do if parents interfere with your communication with the patients? Honestly, I had this problem sometimes. So what do you advise us?
As you said, we're facing many of these situations, especially with the pediatric patients.
And I think especially with the overprotecting parents.
Yes, of course. Yes. We need to be calm. We need to calm the parents, and sometimes we need to take them aside, speaking to them in in a calm tone, and we try to explain to them that the benefits of the treatment and the treatment plan. We instruct them not to interfere while treatment. Even if we cease the treatment, to take this conversation away, then we continue the treatment.
Okay. Thank you so much, Dr. Bashaer. Fortunately, we have Dr. Abdulfatah again. Welcome back, Dr. Abdulfatah.
أهلا وسهلا وأعتذر عن الانقطاع لأسباب فنية.
مو ذنبك. I think it's an internet connection. We really apologize for that. So if you don't mind, can you please share your slides again?
Of course, تفضلي.
Thank you so much. The mic is yours.
So sorry again for the connections, and here the study concluded that the parents and the child, most of the time, they don't mean having SDF as treatment, and they know it would cause black discoloration. The one who have a problem with the SDF as a treatment is us, the healthcare professionals. So here we can see that parents were satisfied with and found SDF acceptable. However, professionals did not, and the article recommended all the professionals to try to overcome the aesthetic concerns sometimes when they offer good treatment for our patients, especially the categories that we have mentioned before. So to sum up, caries remain relatively an issue for us and largely, and it is a preventable disease. The benefits of early initial exam is supported by studies, and it's a habit that you can give it and deliver it to the parents that they should concern prevention. They should come to the follow-up visit more frequently. And in order to do that, you have always to give the advices you need to give. I am not encouraging in my lecture to consider the biological approach for all our patients. You are the best one who know your patients and you know what is the best treatment. We have the conventional approach of managing caries while we remove all the caries and we do our restorative treatment, which is highly evidenced. But sometimes considering biological approach is beneficial when you want to improve the quality of life of the patients, avoid them from having nightmares at night due to pain and any other things. You will relieve the family of having a lot of consequences, and the patients, inshallah, hopefully will not need an emergency treatment anytime soon in the future. And in the time of COVID-19, prevention is the most important. This is the message we should deliver. Thank you so much. Regarding all the references I've mentioned in my lecture, it is all available in full articles. You can contact me anytime to my email directly, or you can contact me on Twitter, and I am more than happy to provide you with the full-length articles. Thank you so much again for Dr. Linda and Dr. Basil for organizing the sessions, and to the AAPD, and I am happy to answer any questions. Thank you again.
Thank you very much, Dr. Abdulfatah, for a well-structured and very informative presentation. We have a few questions from the audience, and basically it talks about the Hall technique. How can you pick the right size of the stainless steel crown before you fit it?
So the whole technique, if you want to choose the crown, it's the same for the stainless steel crown. It's a trial and error. So you have to have multiple sizes and you have to try them on. And when you try the hole or the stainless steel crown over the tooth and you think this is the size it would fit, so do just initial try in, and then you can use the same crown which is best fit the tooth.
Okay, the second question again about Hall technique. Can you use the Hall technique for the MIH first permanent molars?
So we used, see, the whole technique is designed for a primary molar. So when we treat primary molars with this technique, we call it as a whole technique, but we can use stainless steel crown for MIH teeth as a management approach, because we know if we are going to do the conventional restoration by composite or glass ionomer, the rest of the tooth will be prone for post-eruptive breakdown sometimes. So considering doing stainless steel crown, and it's a personal opinion from my limited experience, I always, when I see a post-eruptive breakdown, MIH teeth, the first option I consider is doing stainless steel crown.
So just the regular technique, not the Hall technique.
Yeah.
Okay, thank you. Are there any specific instructions given to patients or parents regarding the SDF, like care, consequences, sequelae?
So for any treatment that we do, there is no 100% success rate. So we are doing the SDF because that we need to buy time, or we want to avoid GA, or we want to arrest the caries. The child cannot tolerate local anesthesia or caries removal, very young children, but there is always a chance that the tooth will not adapt to the technique that we have done, and then the situation will become worse and the child will complain from pain or infection, and at that time we have to intervene and do more aggressive treatment.
Okay, thank you, doctor. More questions again about SDF. What's the fluoride concentration or content of SDF?
So it is the 25% silver, and the fluoride for mineralization is 5%, and we have ammonia for 8%, and the rest is water.
Okay. We talked about the concentration. Can we use sealant on adult teeth? Is it recommended?
Of course, the recommendation, maybe I will go back to the slide. The recommendation by the guideline is for both the adult and primary dentition, and it's a very nice guideline that's highly recommended to go through it if anyone would like to read more about the situation. If you are considering fissure sealant for secondary prevention, if you have uncavitated caries, which is this guideline stated here, the primary and permanent teeth.
Okay, I have a question here regarding potassium iodide effect. Does the potassium iodide affect the bonding strength with restoration when used in combination with SDF?
It's a good question, and it is under investigations. However, it's been investigated as a technique to try to mask a little bit the black stain effect, but there is no good results until today. However, the same company who is giving the SDF is having a glass ionomer cement, which you can use to mimic the effect of the SDF sometime.
Okay, another question here regarding SDF and the Hall technique. Do you consider treatment with SDF and Hall technique as a permanent treatment, or you have to revisit the teeth?
As I mentioned, it is any treatment, conventional or biological, we have to maintain it. We have to have follow-up visits. It depends on the situation itself, the child case, and the expectations. Sometimes some parents are happy with the SDF as an option if it is successful today and for the following years. For the Hall techniques, as we applied for the posterior teeth, of course, I consider it as a permanent treatment unless the child report a failure and any infection or pain.
Okay, a question here again regarding Hall technique. Do you need to give local anesthesia when you're applying the Hall technique?
We don't give local anesthesia at all because we don't prep the tooth and we don't remove the caries. We only cement it. Some children, depends on the pain threshold, they will feel some discomfort, but there will be no pain, so we don't give local anesthesia. And it's designed for this purpose while we want to avoid local anesthesia sometimes.
A question here, does the application of NSSF better than SDF since NSSF does not cause dark stains?
So I don't get what they mean by
I don't know what NSSF.
But I will assume it's type of the fluoride varnish.
Yeah.
It is the least that we can do. So if you have caries, the least that we can do is application of fluoride varnish, and it's proved to some extent slow the progression of the lesion, but it's not better than the SDF.
Okay, many questions from several audience talking about the availability of SDF in Kingdom, and I think you've addressed that issue.
I contacted the company myself the day before yesterday, and they are in the final stages of having a license of distributing the SDF, and they will have an official website, as they said, soon. So they said in June, inshallah, the SDF will be available to be ordered online and delivered, inshallah, to the clinics in the kingdom.
Inshallah. Are you aware? This is a question from me. My understanding that the company manufacturing SDF is working in a new version where the new solution will not stain the dentin as such. Are you
I
aware?
hope so, but I'm not aware of any work that's been done, but inshallah. But what I know that they have two products. They have the SDF and they have a fluoride varnish as well, which is considered to be good.
Well, I know for infection control, they have Unidose now, which is, again, it's a single use. And if you're going to use it on a single tooth, that there are going to be a lot of waste of the material. So if you're planning to use the Unidose, you need to plan for multiple teeth applications. Question again from me, since I believe I addressed most of the questions from the audience. What's your personal experience with Icon Infiltrate?
Icon infiltration is a really good option when we have especially enamel defect or aesthetic concerns in the anterior permanent teeth, and sometimes if we have an initial proximal caries lesion in both primary and permanent teeth. It's a very good approach, and it is promising, and all the patients like it if it's done in the right way and if it is effective. But what do you think, doctor? You can give us your opinion.
Unfortunately, I used it myself. I used it only one time, and that was a trial thing. I don't think it is available locally. I did recommend it for a few patients, as you said, when we have a lot of white spots on the anterior facial surfaces. And unfortunately, again, you know, I asked patients to market to look around, see if anybody has access to that material. Personally, I like it. I read about it. I used it, as I said, one time, and I believe it's a good option for patients with white spots, whether it is because of poor dietary habits or patients upon completing orthodontic treatment and debanding. I think that material has great use.
Thank you so much.
Maybe we have time for one more question here. Can we use GI solution for color? I guess they're assuming, you know, using the GI on top of SDF.
Yes, of course we can use, and as I mentioned, the company developed a special glass ionomer restoration to be done on the top of the SDF. However, we don't know if it will work. It needs more studies to be done. But inshallah, as you said, if we will have an SDF without staining effect, this will be great, and it will be a very good intervention.
Okay, thank you very much, Dr. Abdulfatah. And turning the mic to Dr. Linda.
Thank you so much, Dr. Basil and Dr. Abdulfatah. At the end of this webinar, I would like to thank Dr. Basil AlKhadra for moderating this session. And also, I would like to thank Dr. Bashaer Abdulhadi and Dr. Abdulfatah AlAzmah for their informative and interesting lectures. I would like to take the opportunity to announce for our next webinar, which will be on 6th of May. Unfortunately, this will be the last webinar in Ramadan, and we will meet, inshallah, after Eid. For the next webinar, we have distinguishable speakers. We are going to host Dr. Fahad Al-Zubi and Dr. Ala Hani. Dr. Fahad Al-Zubi will present a lecture about management of dental trauma, and Dr. Ala will present a lecture about different biological approaches for caries management. I really advise that you attend this webinar, and you can follow our official webpage and our Twitter page for further updates for our future activities. You can also subscribe to our YouTube channels. And I noticed that we have many questions regarding certification and how can you get the accreditation hours. I would like to clarify that accreditation hours is only for the SSPD members. And the certificate will be emailed to the registered email that you register in the link to enter the Zoom program. And if you have any question regarding you joining the society or renewing your membership, just please contact us at our email sspd.saudi@gmail.com, and we are so inshallah, and we will answer all of your comments and your questions. At the end, I would like to say thanks to Kunuz Ritaj Company and thanks to the SSPD, Dr. Aziz Al-Jawhar, the president of the SSPD, the scientific committee, Dr. Maral Malik, Dr. Ahmad Badawi, and Dr. Dani Agili, and all the members of the society for all of their efforts. Thank you so much for attending and being with us tonight. I really wish that you had a great and beneficial time. And at the end, remember, stay home, stay safe, and stay positive. Thank you so much. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Dr. Renda. Thank you, Dr. Manal. يعطيكم العافية and all of the committee على التنظيم والترتيب والأفرد. جزاكم الله خير وكل عام وأنتم بخير.
أنتم بخير وصحة وسلامة.
العفو، شكرا جزيلا، يعطيكم العافية جميعا.
أهلا فيك، أهلا فيك، شكرا.